So our next distinguished speaker is Professor Chowdhury Hafizul Ahsan sir. His name needs not any introduction. He is well known in the society, home and abroad. He is a clinical professor of medicine by the University of Nevada School of Medicine and director of cardiac catheterization laboratories and cardiovascular research at the University Medical Center. Recently, his contribution to the vaccine program through COVAX is well known not only to the Cardiac Society but all the peoples of Bangladesh. We, on behalf of our organizing committee, would salute and give our gratitude to you for your huge contribution to this program, sir. Off to you, sir, for the presentation. Thank you, sir.
Thank you so much. It's always a pleasure to join this kind of program, and I really consider this as a distinct privilege and honor to get the invitation. So this is a little different issue when we deal with non-ST elevation MI. I call it as a mixed bag of patients. And in some way, STEMI is easy to sort out. And we have a very definite pathways in terms of primary PCI, fibrinolytics. We talk about pharmacoinvasive and then tackle that way. Compared to that, we have the huge burden of handling this mixed bag of patients. We call it non-STEMI. Let me start with a patient, 51-year-old, diabetes, hypertension, had a cath in 2018 without any significant coronary artery disease. She comes in with this chest pain and this EKG, precordial, little bit looks like a T inversion in the precordial list, some ST depression, lead 1 in AVL, and then cholesterol is really off the roof. LDL before was 160 something, and now not even calculated. Last time, 2018, it was 169. So this patient, if you look at this initial presentation, the troponin at the top, the fellow put it in. This is the new troponin with this basically negative. So if you look at this cath from 2018, it's actually no significant coronary artery stenosis, and you may say there may be some non-significant CAD in the LAD, and then he did not have any follow-up. And now 2021, no surprise, there is progression of the plaque, but even more importantly, there is a significant, this is a left dominant system, and there is a significant stenosis in the left PDA, which was intervened. Compared to that, remember this patient had symptomatology suggestive of angina and high risk, and this patient, compared to her, 64-year-old with hypertension, diabetes, CRI, previous history of TIA, and received oxygen morphine in the emergency room, started heparin, and this EKG. So this is global ST segment changes, AVR ST elevation, and this was the cath. So my question is that how we tackle this. So this is of course a high risk patient clinically, high risk patient angiographically, and we intervened, and then PCI done. We know now pathophysiologically there is the plaque rupture, plaque erosion, activation of the coagulation cascade, and the platelet activation. Concept-wise, we know this is similar to the STEMI. However, we don't see the ST elevation. There is usually non-occlusive vessels, and we know the plaque progression can go from stable coronary to really severe stenosis, rest angina, to plaque rupture, plaque erosion, and activation of the coagulation cascade and the platelet activation. And therefore, the theme of the therapy is anticoagulation and antiplatelets. We don't need to remember any of this now. We can simplify that we need the anticoagulation and antiplatelets. And the earlier in the beginning of this journey, we said, okay, if anything bad, go early. If anything not bad, go conservative. But it's really about risk stratification and how to assess risk and how to intervene. If you look at the TIMI risk score and TIMI high in the beginning, when there is STEMI, we run and we go after the STEMI. And in the non-STEMI, we kind of a little bit slow and we don't give as importance. But my talk today, I'll focus that the non-STEMI with very high risk, they catch up. And if you look at this death MI at 30 days, death MI at 1 year, the high risk TIMI 5-7, they actually is very high. And no matter how you look at the risk score, pursuit risk score, TIMI risk score, or GRACE risk score by the Europeans, high risk means bad news. It may be not as bad in the immediate hospitalization period, but over time, it is going to get worse and the outcome is bad. So therefore, and this is another one, that absolute troponin value, it has something to do. In the TIMI risk score, we talk about troponin positive or negative in a binary way, but absolute TIMI, absolute troponin has value. Very high troponin, the likelihood is that is going to be very high risk, as you can see from the high mortality with the very high troponin in 40 days. So what we learned over the years, that risks is important to assess because they are at high risk for bad outcome. And the question is, this debate of invasive versus conservative is a moot point. That debate is over because we need to really look at how we can then address these patients who have moderate or high risk, very, very low risk, or the patients who are triaged by heart score in the ER. Those are different. Once ruled in non-STEMI, and then you risk stratify them moderate, high, you really need to think about intervention. And today's talk is how early. This is 2004 after the Pursuit study, and then with the Crusade registry, this is Deepak Bhatt showing that if you do early intervention within 24 hours, you have a better outcome in terms of in-hospital mortality. In-hospital mortality. So this is important thing to notice. And this is Christopher Cannon and Braunwald proposed long time ago that if it is really high risk, dynamic EKG changes, refractory heart failure, non-sustained VT, post-arrest with return of circulation, dynamic EKG changes, those are very high risk. We should go for early intervention in this group. This is 2002. And I'm going to show you in a second, in the 2020 ESC, now they are addressing, but before they address this, they tell us that you need to think about the risks and also the bleeding. So anticoagulation, antiplatelets, this is all simplified. Heparin by bilirubin or low molecular heparin, and then start with antiplatelets. And then after the intervention, go for dual antiplatelet. You really don't need to do the dual antiplatelet upstream. You really don't, particularly if you're thinking about going early. So these are the advantage and disadvantage, and conceptually it may look like attractive to give upstream 2B3A inhibitors or dual antiplatelets, but there is downside also. See, in the trial, it did not really pan out that we are obligated to use upstream intensive antiplatelet. However, anticoagulation is recommended. Very early on, as we learned from Dr. Braunwald's proposition, now the ESC is saying, if it is really bad, hemodynamic instability, recurrent refractory chest pain, arrhythmias, and dynamic EKG changes, and look at this, ST elevation, AVR, and depression in other leads, like my case, then you really should go early and look at the level of evidence, C. That means consensus. These are not the patients in the trial. you may not see them in the trial because it is too risky to take them into trial. However, the rest of the people we need to do with the greatest score. This is Europe, but in case of US, we do the timidity score. It's all the same, 5, 7. Those patients should go within 24 hours. So question is that all true? Is it 24 hours or we can do 12 hours? Within 12 hours, and this is verdict trial, that did not really show much of a difference. However, when they do it in early trial, without the oral antiplatelets, just aspirin, not a second one, and then go earlier, there is a reduction in recurrent ischemic event. However, if you look at the composite endpoint, but tease out the death from the recurrent, is the ischemic event was primarily prevented if you go early. So how we sum it up? We sum it up this way, that we assess the patients with non-STEMI. It's a mixed bag. We find out who is very high risk. We talked about, hemodynamic instability, recurrent chest pain, refractory angina, life-threatening arrhythmias, mechanical complication, of course, cardiogenic shock, and then bad EKG changes and dynamic EKG changes. This is high risk. High risk is those where you do all the patient profile and the patient's troponin taking into account, no matter how you do it, GRACE or TIMI or Pursuit. If the patient is high risk, we go next day and try not to do this 3 days later on a Friday case, do it on Monday. That's not probably a good idea. In a low risk patient, you can do either way. You can even think about avoiding angiogram altogether. So this is 40-year-old chest pain, elevated troponin. This is EKG, and then some changes. And then if you look at this carefully, there is actually wall motion abnormality in the anterior wall. And this patient went to the cath lab, and right is good, and this is the LAD. So not all non-STEMIs are equal, and by definition, non-STEMI is type 1 MI. But if it is spontaneous coronary dissection like this one, it actually is a type 2, and you probably need to think that it may look like, smell like, taste like non-STEMI, but it may not be pathophysiologically non-STEMI. And the classic teaching is that if you cannot avoid it, you cannot probably better to avoid and treat medically. So that's what we did. Patient did fine, and subsequent follow-up was good. Compared to that, if it is a 75-year-old chest pain and then small troponin, but patient had a previous left circumflex stent and then EF bad, and then look at this patient, that this previous ICD and then distal left main, and then calcified vessel. We actually had to do rota and then put a impeller balloon support for avoiding complications, and we had to do this in a planned way. However, because of the ongoing angina, we had to go early, and this was done primarily because of surgeons turn it down. So the non-STEMI is a mixed bag of patients. We really are obligated to find out who is the patient, what are the patient's risk profile, what is the clinical presentation, does the patient have any red flag in terms of dynamic EKG changes, ongoing pain, refractory angina, the patient has VTAC, resuscitation from the cardiac arrest, B-fever arrest, cardiogenic shock, hemodynamic instability, bad angina with heart failure, and then nasty EKG changes and very high troponin. Whatever way we look at, we really don't need to memorize. We need to remember the concept. The concept is it really, really high risk? that we cannot afford to wait, then don't wait. We need to go now, which is within 2 hours, it is reasonable expectation. And then go for within 24 hours, look at the logistics, look at the other patients who is at high risk, but we can wait. But we in the COVID time are perplexed. If we can explain the scenario by severe hypoxia, hypotension, another cause can be labeled, don't call it non-STEMI. This is probably type 2, and maybe you can buy time and hold hand with other disciplines. And tincture of time is a good thing. And be aware with the imaging studies that there are other non-STEMI mimics. Who knows, it can be a SCAD. Sometimes we are fooled by the Takasubu, and also in a small cohort, probably a significant cohort, we'll see as Minoka, MI with no coronary obstructive disease. So I will stop there, and then I can take some questions. In fact, when I'm in this talk, I was called by my hospital that there is a 46-year-old with EKG changes, dynamic, refractory to all the therapy they are giving, and having rising troponin. So I'm just going and doing cath tonight, although this is non-STEMI. But this is, I'm calling it high risk and not responding to therapy, and we cannot wait. Thank you.